Thanks,
Okay, can I start? Welcome to this webinar, APSC Cloud Forum of Cardiovascular Disease Series. My name is Ono from Kyoto University. Next slide, please. In order to prevent cardiovascular disease throughout one's lifetime, it is crucial to implement strategies targeting atherosclerotic cardiovascular disease, ASCVD, and major adverse cardiovascular and cerebral vascular events, MACCE. Today's webinar will discuss the following key points. First, how and when to initiate reduction of atherogenic lipids. Second, how to manage multiple atherosclerotic risk factors using a single tablet across the general population. And third, the initiation of early hypertension management with low-dose triple or quadruple monotherapy antihypertensive agents. And finally, the management of LPA, a new risk factor, as well as strategies to address the smoking paradox in smoking cessation policies for coronary artery disease interventions. Next slide, please. And today's chairperson are myself, Ono from Kyoto University, and next slide, please. Dr. Yu Chen Wan. Dr. Wan is Associate Professor at the Department of Medical Laboratory Science and Biotechnology, Asia University. And then next slide, please. There are a few important notes. And the content of this webinar is copy-edited by APSC and may not be distributed without prior permission from APSC. The views and opinions expressed in the webinar are those of the presenter and do not necessarily reflect the views of APSC. The live streaming content of this webinar can be viewed on the APSC Cloud, APSC Facebook, and YouTube pages. And then let's get started. Dr. Wang, please.
Thank you, Professor Uno. I'm Yu Chen Wang from Asia University Hospital in Taiwan, and today I would like to introduce the first speaker, the Professor Nguyen Thanh Huang, who is the Associate Professor from Son Nhat Hospital in Ho Chi Minh City in Vietnam. And today his topic is the cardiovascular risk factors and the real-world landscape of dyslipidemia management achievement in Vietnam. And so, Professor Huang, please.
Thank you so much for your introduction. So, good morning. Today is my honor to share with you a topic titled Cardiovascular Risk Factors and the real-world landscape of dyslipidemia management achievement in my country, Vietnam. So, to begin, let's discuss cardiovascular risk factor in Vietnam. First of all, we take a look at cardiovascular disease mortality rates in Asia countries. And Vietnam ranks third in Southeastern Asia. And in this area, you can see that ischemic heart disease and strokes are the leading causes of cardiovascular death. Indeed, now Vietnam has a health transitions with increased morbidities and mortalities from non-communicable diseases, for example, hypertension, coronary disease, diabetes, and in 2017, you can see here, strokes and ischemic heart disease. The two atherosclerotic cardiovascular diseases are the leading causes of death. And data from 2019 once again confirmed that the two diseases, including ischemic heart disease and ischemic strokes, were the leading cause of death and disabilities in my country, Vietnam. So, what are risk factors for atherosclerotic cardiovascular diseases? You can see here many risk factors, and they can classify into non-modifiable, for example, genetic, age, sex, race, and modifiable risk factors. For instance, elevated levels of LDL cholesterol, hypertension, diabetes, smoking, obesity, physical inactivity, environmental factors, as well as social determinants of health. And in this study include more than 2,000 Vietnamese people in general population in Vietnam. You can see here, this lipidemia were the most prevalence of ASCVD risk factor, followed by hypertension, smoking, as well as diabetes, obesity, drinking, physical inactivities, and having stress. And please, importantly, passive smoking is also a major health issue in Vietnam. And the home being the most common environments for passive smoking from male family members, such as fathers, grandfather, they smoke in the house. And to further understand the ASCVD risk factor in Vietnam, please take a look in this table to more detailed information. And you can see here, hypertension, diabetes, the prevalence of them are increased with age in both genders, women and men. The number two is dyslipidemia and unhealthy diet. Unhealthy diet, for example, high salt or low fruits and vegetable consumptions are very prevalent in both gender. Thirdly, current smoking and excessive alcohol intake are more prevalent in men than in women. And the last one is men tend to have more risk factors than women in Vietnam. So please take hypertension for an example to compare from Vietnam to another Asian countries. And you can see here, the burden of hypertension in Vietnam is a misgrade compared to another Asian country. So what happened in our country? One of the reasons of the high burden of hypertension in Vietnam is that high average daily consumption of salt. For example, about 18 grams per day compared to the WHO recommended limit only below 5 grams per day. And how about on the population in Vietnam? In this study, include more than 1,000 Vietnamese on the patients, and 86% of them had hypertension, and 1 in 4 were affected by diabetes or obesity. So we should not forget air pollution, important in the world, important risk factor in the world. And in Vietnam, transportation is a primary contributor to air pollution. And you can see here in our city, Ho Chi Minh City's air pollution and heavy traffic in the rush hours with many cars and motorbike suddenly caused the air pollution in Vietnam and affect heart disease. So we move to the real world landscape of dyslipidemia management achievement in our country. This wonderful paper have just published in 2025 showing the prevalence of dyslipidemia across the regions in Vietnam. And you can see here, Central Vietnam has the most prevalence of dyslipidemia at 78%. And among men, elevated triglycerides follow up elevated total cholesterol and LDL cholesterol were the most prevalent. And among women, elevated cholesterol follow up elevated triglycerides, LDL cholesterol were the most prevalent. So you can see the pictures of dyslipidemia in my country, Vietnam. And this study also found that diabetes, hypertension, abdominal obesity, and overweight obesity were significantly positively associated with dyslipidemia. And importantly, although not statistically significant, but physical inactivities was also observed to increase potential to increase the risk of dyslipidemia in my country. And how about achieving dyslipidemia achievement goal in Vietnam? This study include not only chronic but also acute patients with chronic and acute coronary syndrome. And you can see here statins were used nearly in all cases. However, most patients was on statin monotherapy with low or moderate dose of statin. So this may be the reason that by the former follow-up after acute coronary syndrome, only 27% of the patients have achievement of LDL cholesterol below 70 milligram per deciliter. So how about on the population? This study includes on the patient with type 2 diabetes and very high CVD risk. And you can see here, 89% did not achieve aggressive LDL goals of below 1.4 milligram per liter. This study also found that obesity can increase the probabilities of not achieving the LDL goal, whereas high-intensity statin therapy can decrease these probabilities. So these results remind us that the use of high-dose statins or combination therapy with another drug, for example, ezetimibe or PCSK9 inhibitors, is very important to achieving LDL cholesterol targets. And we move to how to control cardiovascular risk factors in Vietnam. I propose 4 ways, and all of them now applying in our countries. First, policies and healthcare system level intervention. For example, national screening program, particularly targeting those over 40 years old. Tobacco and alcohol control. We need to control the use of tobacco and alcohol. And so reduction targets below 5 grams per day. Second, community-based intervention, for example, health education, community screening, and monitoring. Third, individual lifestyle modification. I think it's very important. Stop smoking, healthy diet promotion, physical activity encouragement, weight management, and stress reduction. All we know that it's difficult to control stress, but we need to talk with our patient how to reduce stress in their life. And the last one, I think also important that medication and clinical management. For example, how to use appropriate medications with correct doses. And the last one is we need to remember to control comorbidities, such as hypertension, dyslipidemia, as well as diabetes. So, in conclusion, cardiovascular risk factors are present everywhere, including Asian region. And controlling cardiovascular risk factor, including dyslipidemia, very important to reduce the burden of cardiovascular events. Thank you so much for listening. This is a photo from my Vietnam, in the north of Vietnam. And if you have free time, please come to my country. Thank you so much.
Thank you. Thank you for Professor Huang for your excellent talk. And I think that you provide a very comprehensive speech regarding to the how the dyslipidemia treatment in Vietnam. And is there any questions from floor, from the chairperson, or from other speakers? I think that we may have more than 10 minutes for the discussion. And let me raise the first question. And I think that it's very interesting to see that you have just mentioned that the air pollution seems to have some strong correlation with the cardiovascular disease in Vietnam. And is there any epidemiology studies to compare the different areas of the prevalence of the cardiovascular disease according to the severity of air pollution in different regions in Vietnam?
Oh, it's wonderful questions. And 2 years ago, I performed a small research, and I found that there is the difference of the prevalence of cardiovascular disease between urban and rural areas. And we can know that in the rural area, we have fresh air, and we have the low prevalence of cardiovascular disease in rural area compared to the urban areas in Vietnam. Yeah.
Yeah, I think that there are some epidemiology studies in East Asia, no matter in East Asian or other regions in the world, to see the correlation between the air pollution and the cardiovascular disease prevalence. I think maybe we can have more research in the future. And other questions? And I think that you have also mentioned the low LDL achievement rate in Vietnam, especially in high-risk patients. I think it's also a global problem, not only in Vietnam, but also in East Asia or in all over the world. And can you just do some more analysis for the reason why the achievement rate is so low? Is due to the drug cost or patient's physician inertia or patient factors?
Thank you for your questions. In my opinion, there are two main reasons of the low achievement of the dyslipidemia achievement goal. The first is the patient receives only statin monotherapies and with the low or moderate dose. The second is we need to combination. We need to use combinations of statins with another drug to control the dyslipidemia treatment goal. For example, combine statin with azithromycin or PCSK9 inhibitors to improve the achievement of dyslipidemia treatment goals.
Okay, thank you. And the chairperson, Professor Uno,
okay.
Do you have any comments? Oh,
okay. I was surprised that the smoking rate in men was so high in your country. And you said that one of the strategies to reduce the number of the people who smoke is to provide counseling. And do you think that is effective or that is enough?
I think it's not easy to persuade a man to stop smoking, but we have to try. Every time when I talk with my patients and he's smoking, I also talk with her, discuss with her, with him to persuade him to stop smoking. But not easy, not easy, very difficult.
And also, can I ask you the current trend of the percentage of the smokers? Is it decreasing?
I think maybe decrease. I need to perform a new survey to confirm the prevalence of smoking in my country.
Okay, thank you.
Transitions from the traditional smoking to electric smoking, especially in the younger adults. It's also important.
Yes.
Good. Any other questions from the floor?
Yes, I am Professor Rajkumar from Pakistan. I just want to comment that despite of these conferences, awareness programs, I don't know why the young people are at the more risk. And as you said, that smoking in young people is rising, and this thing is more in low and middle income countries. So we need to hammer and we need to work hard to aware the masses properly.
Yes, I agree with you. Yes.
Yeah, I think another interesting point you have raised is the extremely high salt intake in Vietnam's population. And do you think it's due to the culture, or is there any good strategies to reduce the salt intake from the public health point of view?
I think the government should do more and perform more strategy to control the pollution and to decrease the prevalence of cardiovascular disease in my country. It's not easy, not today or tomorrow, but it needs years, months, or decades. Yes.
Yep. Okay. So, is there any questions from floor or? Okay. So, if no more questions, and thank you, Professor Huang, for your excellent talk. And let's move to the next speaker. I would like to introduce the next speaker, Professor Rajakumar Sachidovai from Pakistan, which is a professor of the Sachid Mohtama Bazar Bhutto Medical University. And today, the topic he will present is the polypill comprising statin, ARB, beta blocker, and thiazide thiazide plus aspirin reduce MACE in whom without ASCA. Implications of TIPS 3 trial. Let's welcome Professor. Yeah. Can you share your slide? Thank you.
Is it okay?
Not yet.
Just a minute. Just a minute. Hello. Free. Is it okay now?
No.
Why there is problem in sharing? Where is just a minute.
Do you see the share button? The button lower corner.
I do see, but that is not sharing.
Share and click share, and you will see your PowerPoint and some other windows. Click the PowerPoint window and click the start sharing.
Just is it okay?
It's coming. Okay. Yeah.
It's coming.
Okay.
Okay.
Done.
Thank you. Very clear. Thank you.
Okay. First of all, I am grateful to this forum that they have provided me an opportunity to be the part of this academic session. So I am going to talk on the polypill comprising statins, angiotensin receptor blockers, beta blockers, and thiazide plus aspirin reduce major adverse cardiac events in home without atherosclerotic cardiovascular disease, implications of TIPS 3 trial. So these are the contents of my talk. So polypip is, as you all know, it's a fixed dose combination medication designed to simplify cardiovascular disease prevention. Typically, it includes. Hello.
Okay, please carry on.
Typically, it includes statins, antihypertensives, and antiplatelet agents, aiming to enhance adherence, reduce pill burden, and improve health outcomes in at-risk population. So the background is this, that it aims to simplify treatment regimens for cardiovascular disease by combining multiple medications into single pill. As I already said, in low and middle income countries, cardiovascular diseases are at rise. So the polypill concept emerged in early 2000s as a strategy to simplify cardiovascular disease prevention. Its objectives include enhancing adherence, reducing healthcare costs, improving population-wide health outcomes through proactive prevention strategies. As we all claim that prevention is better than cure, but we need to do a lot. So the polypill was the first coined by Nicholas and Walt Malcolm Law in 2003. They proposed fixed dose combination pill containing several cardiovascular disease drugs, statins, blood pressure lowering agents, aspirin, and vitamins to be given to everyone over 55 years old and those with existing cardiovascular disease to reduce heart attacks and strokes dramatically by up to 80%. The International Polycap study, that is TIPS trial, demonstrated that the polypill combining statins, beta blockers, thiazides, and ACE inhibitors plus aspirin significantly reduced major adverse cardiovascular events in adults without established atherosclerotic cardiovascular. This is the point to be noted, that this study was conducted on the patients who are not having established atherosclerotic cardiovascular disease, but at intermediate to high cardiovascular risk. So this was a multifactorial trial randomization was done, and 2 arms were selected. One was given polycap active and other was placebo. And in both the polycap, there were all the 4 drugs present. And then in both arms, one group was given aspirin and other was not given. And then again, vitamin D was added, and another group, vitamin D was not added. And interestingly, 9 countries participated, people of the 9 countries, and most of the people were from India, followed by Philippines, Colombia, Bangladesh, Canada, Malaysia, Indonesia, Tunisia, and Tanzania. So the study has randomized 5,713 participants across 9 countries. Mean age of the study population is 63.9 years, and 53% are females. So more than 50% are the females. Mean interheart score was 16.8 and is consistent with the study population at intermediate risk. So results of the TIP3 study will be key to determining the appropriateness of fixed dose combination therapy as a strategy in global prevention of the cardiovascular disease. Now, what are the clinical implications? Let me tell you that it provides important implications for primary prevention in high-risk patients without established atherosclerotic cardiovascular disease. Effective risk reduction. It was seen that when aspirin was added with the polycap, then it led to the reduction in 31% compared to the double placebo in adults at intermediate to high risk, supporting its use for primary prevention in this population. Improved adherence was also seen when the polypill was used. Broad applicability. The trial included participants from diverse, mainly low and middle income countries, demonstrating the feasibility and effectiveness of this strategy in various health systems. And there were no safety concerns as there were no adverse events. Cost and affordability. While the polypill increases cost in lower and upper middle income countries, it remains affordable at population level and is cost neutral or even cost saving in high income countries. Shared decision making. The results support a polypill based approach for primary prevention, but guidelines emphasize lifestyle optimization and shared decision making, especially regarding aspirin use in primary prevention, because there were people who were having the fear of bleeding. That was the reason. So rationale for use in cardiovascular disease: by integrating multiple agents, it can effectively lower blood pressure and cholesterol, ultimately reducing overall cardiovascular risk and improving patient outcomes. So patient compliance and acceptability is the main problem. The polypill concept enhances patient compliance by simplifying medication regimes, thereby improving adherence to cardiovascular disease prevention strategies. So global perspective and adoption. So the implementation of the polypill for cardiovascular disease prevention varies by region, with significant usage in high-income countries compared to lower-income regions where access and healthcare infrastructure hinder widespread adoption. Efforts are needed to enhance awareness and facilitate accessibility in underserved populations. So scientific and clinical challenges. Efficacy and safety concerns regarding polypill implementation include potential adverse drug interactions, variability in patient responses, and uncertainties about long-term outcomes. So people were doubtful that whether in long run it will work or not. These factors can hinder widespread adoption and necessitate thorough clinical trials to confirm benefits in diverse populations. And the target population selection for polypill implementation faces challenges as identifying high-risk individuals, ensuring adherence among diverse demographics, and considering varying comorbidities. Tailoring the polypill to a specific population is crucial for maximizing its efficacy in cardiovascular disease prevention. And that is why our target population, we have the scores like interheart score and the atherosclerotic cardiovascular disease score, so that we can easily judge that who are the people at high risk. So patients' public perception and awareness is very much important. Patients' education is crucial for successful polypep implementation. Effective communication strategies and tailored educational programs are necessary to enhance understanding and acceptance of among diverse populations. So healthcare providers often express concerns about the efficacy and safety of the polypills, fearing potential resistance from patients and the medical community. Additionally, lack of awareness and training regarding polypill benefits may hinder their acceptance in clinical practice, impeding overall implementing efforts. So, tailored polypill approach could enhance cardiovascular prevention by customizing combinations of medication based on individual patient profiles, risk factors, and adherence level. So, and also this is the one thing that incorporating new therapies may help in making new guidelines and further prevention of the cardiovascular disease. So further polypill formulation should integrate novel therapeutics such as PCSK9 inhibitors or SGLT2 inhibitors, enhancing cardiovascular risk reduction. So implication of the practice, that is important, apply all those things which we say that clinicians should consider implementing polypills in practice for primary prevention of cardiovascular disease, emphasizing individualized patient assessments, continuous monitoring and adapting treatment plans based on patient response, and emerging research can enhance efficacy and adherence to therapy. And policy implications, the findings from TIPS 3 randomized trials underscore the need for policy reforms that support the integration of polypills into standard preventive care protocols for cardiovascular disease, aims to enhance accessibility, adherence, and overall health outcome within population at risk. So the future outlook for the polypills' role in cardiovascular disease prevention hinges on broader adoption clinical practice, more extensive long-term studies, and addressing adherence barriers. Approach could significantly enhance population health by simplifying prevention strategies and improving patient compliance. So we need to engage stakeholders. That is crucial for successful implementation of the polypill strategy in cardiovascular disease prevention. Collaborative efforts among healthcare providers, policymakers, and communities can enhance awareness, support such research initiatives, and drive policy changes, ensuring effective dissemination and uptake of the polypill approach. So continuing education and research, ongoing education and research are crucial for effectively implementing polypills in cardiovascular disease prevention. Healthcare professionals must stay updated on emerging evidence, while studies should focus on long-term outcomes, adherence, and diverse populations to enhance understanding and optimize patient care. So thank you very much.
Thank you for Professor Sachibani's excellent talk. And I think that you just present a wonderful talk and present the result of TIPS 3 studies. And first I would like to congratulate for the excellent result of your study, and I think that it will provide more one of the potential strategies in the future to enhance patient compliance and to reduce the cardiovascular risk. So, is there any comments or the questions from the floor? Professor Uno, do you have any comment?
Okay, thank you very much. And I think to use the polypills is quite important to increase the adherence for the patients. And when using this kind of drugs, it is difficult to change the dosage of each drug. How do you handle it?
Hello. In this study, the doses were half of the doses of the medication were added. And that is why in different groups, acceptability is different. And that is why I said that we need to study the region-wise. And the people, according to the scores, that who are the high risk, who are the intermediate, who can tolerate the drug, we have to see and we have to follow. That is the reason. And if you see, most common cardiovascular disease is hypertension. And the most common cause of uncontrolled hypertension is that 77% people are not compliant fully. That is the main reason that I always said that we doctors and we the healthcare providers do not aware the masses properly. Regarding your, as I said, that dosage was half half of the doses were included. So to prevent, and we need to follow those patients, that what are the tolerance, what are the complications, what are the side effects of the drug. And in this trial test, 1/4 of the actual dose were given, and that was the reason.
Okay, thank you.
Thank you. And I know we know that the advantage of the polypill is to enhance the patient compliance. We also know that the potential drawback of this strategy is that the lack of flexibility. That means we may have the difficulties to adjust the medications if this is necessary. And I think that in the TIP3 studies, the study population is a patient with intermediate ASCVD risk. And I have noticed that the polypill, the content of polypill just include the content aspirin. And do you think it is justified to prescribe the aspirin for the patients with intermediate risk? And otherwise, should we just do the tailored therapies, just like to adjust the content of the polypill for the high risk and intermediate risk patients? Thank you.
I think we should give polypill to the intermediate risk people, because our aim of the polypill is basically to prevent the development of atherosclerotic disease. Regarding your question of aspirin, so that there are certain reservations, and we have to see that what are those patients who are at high risk for bleeding, and those we are not going to use. But those who are not at bleeding, high risk bleeding, but they are at high risk for the development of atherosclerotic cardiovascular disease, then we may use that aspirin.
Okay, and I'm just curious about in your daily practice, what's the most common facing challenge do you face when you prescribe the polypill to your patients? For example, maybe they will, if they have some complaints or just doubt about the drug side effect, and how do you explain to your patients?
Initially, we have to aware the masses that it is better to take 4 pills rather than 1 pill. If we are having naturally any patient of acute coronary syndrome or whom we think that he is high risk, then naturally we have to give the basic drugs like aspirin and statins, and if he is hypertensive, then naturally antihypertensive medication, and if he is having all those risk factors, then we must give all those drugs. But if we are giving 4 drugs rather than all those 4 drugs in 1 pill, I think that will be easier for the patient to comply properly to take. Otherwise, what will happen if you are writing 5 drugs, patient will go to the medical store in our region and ask which one drug is giving me energy. He will say you must take vitamins. So he will only take vitamins, but he will avoid to take, because there are a lot of issues in our health setup, that as I told you, middle and lower income countries, there is income problem. So that is why it is better to aware and educate the masses, and also the policymakers and all the stakeholders should be taken on the board.
Okay, thank you. And I think there is a message from the Professor Khalida Sumaro. He said that in the nice presentation, and polypill concept is beneficial in the regions where lack of education and awareness to improve taking drugs regularly. Okay, I think it's the professors from Pakistan. His feedback. And I'm just another question is how the cost of the polypill. Is this more cheaper than the free combination, or the higher than the free combination?
It's a bit higher than the individual combination, but it has been seen that it's cost neutral. It's not in long run, if you'll see that it does not produce more cost for the patient or more burden for the patient. But it will be naturally, if the patient will take all those medications in one polycap pill, then what will happen, that it will have the advantages of all those diseases. And if individually he cannot take 4 drugs, then naturally it will not be a cost burden over the patient.
Okay, thank you. And other questions from panelists, from other speakers or chairperson? Or okay, And if there's no other questions, and thank you for Professor Sachurito for your excellent talk. And let's move to the third speaker. I would like to introduce the Professor Satoshi Hoshide from Japan. He is the professor of the in the Jichi Medical University School of Medicine, Tochigi in Japan. And today his talk is about the low-dose triple or quadruple single pill combination BP-lowering drugs for initial hypertension management. Better strategies than conventional drug layering. I think that's the topic of his talk is also correlated with the polypill combination. And let's welcome Professor Satoshi Hoshida.
Thank you very much for Chairman. I cannot switch. My slide is coming.
It's coming, but can you show the full screen? Can you show the full screen to the audience?
Okay, my slide is full screen.
Not
No.
yet.
It's
No.
editing mode.
Just a moment. Now under waiting.
Okay. Okay.
Okay.
Great. It's coming. Thank you.
Okay. Thank you very much. My name is Satoshi Hoshide from Jichi Medical University, is a Tochigi Prefecture in Japan. My topic is lifetime management. Sorry, my topic is the role of triple or quadruple single pill combination blood pressure lowering drugs or hypertension management. I know this project. This slide shows how lowering the systolic blood pressure reduces risk of stroke and cardiovascular event. On both graphs, the x-axis shows how much more the experimental group reduced systolic blood pressure compared to reference group. The y-axis shows the odds ratio. Lower value mean lower risk of stroke of cardiovascular event. Yellow dot means that greater reduction, placebo control trials, and blue dots are activity control trials. As you can see, greater reduction in systolic blood pressure are linked to lower risk, especially for stroke, as well as cardiovascular event. This trend is statistically significant. Overall, this supports the idea that even moderate blood pressure reduction can significantly lower cardiovascular risk. In my work, we performed a retrospective study for the predictive value of home blood pressure monitoring. Home blood pressure monitoring was known as out-of-office blood pressure, which provides more prognostic power than office blood pressure. As you can see, especially in the morning, home blood pressure, increasing morning blood pressure level are associated with stroke event in Japanese population. Right table shows that in the discrimination model of blood pressure index for stroke event, adding more morning of home SVP improved model for stroke event. compared to base model, including office BP level. The results show that the morning blood pressure measurement is an important strategy for hypertension treatment. So Japanese Society of Hypertension guideline strongly recommends the home blood pressure measurement in clinical practice. However, in spite of the fact, our country has a major concern. This chart shows the estimated distribution of hypertensive individuals in Japan in 2017. The largest group, 33%, about 13 million people, are unaware and untreated, a major concern for public health. Untreated and unaware hypertension. 29% were treated, but still have uncontrolled blood pressure. That means treatment alone is not always effective. And just 27% are treated and controlled, but which is encouraged, but still a minority. In total, about 2/3 of Japanese population with hypertension either remain untreated or have poor control. Here is the chart comparing hypertension across countries. How many people have hypertension, how many know about hypertension, get treated, and have it under control. If we look at Japan, you can see the problem. For women, only 29% have their blood pressure control. For men, it's even lower, just 24%. That's one of the lowest among these countries. In contrast, for example, like Canada or USA show much better control, approximately 70%. So in Japan, even when people are treated, many patients aren't reaching proper blood pressure control. This shows we need to improve not just treatment rates, but also how effective that treatment is. In treated patient, from our data, which enrolled about over 2,000 treated hypertension treated patients with more than antihypertensive drug, about 50% patient were controlled both office and office and home blood pressure. However, even in increased number of antihypertensive drug, the control rate does not increase. We typically start with monotherapy, hypertension monotherapy, then titrate the dose, and only after that consider adding a second or third agent if the patient remains uncontrolled. But first, this stepwise strategy delays the achievement of blood pressure target, often by weeks or months. Second, monotherapy has a limited serum efficacy. Most antihypertensive only reduces the blood pressure by about 9 to 10 millimeter mercury on average. Third, once we move to add multiple drugs, particularly in separate pill, polypharmacy becomes an issue. The patient adherence starts to drop. Now, in the real world, a significant proportion of patients fail to reach their target blood pressure even after 3 months of treatment, especially if managed through this conventional titration model. Let me introduce the finding from the Korean nationwide study that evaluate how different types of antihypertensive regimen impact medication adherence in real-world setting. This bar, 3D bar graph shows a medication possession ratio, which reflect how consistently patient fill their prescription. The higher the MPR means better the adherence. On the horizontal axis, we see the number of pills, and the color of each bar represents the type of antihypertensive regimen. As shown here, the adherence was consistently highest in the group receiving single pill combination therapy, regardless of how many total pills the patient was taking. This suggests that simplifying the regimen, even if multiple medications are still required, can significantly improve adherence. Now, let me talk about the value trials published about 20 years ago. This result is interesting. This study investigated the impact of different antihypertensive regimen, amlodipine and valsartan ARB, on cardiovascular outcomes. On the left side slide, let's figure show this left figure. You can see the mean systolic blood pressure over time in two treatment groups. One receiving the valsartan and the other the amlodipine. Although both regimen eventually achieved similar blood pressure level. There was a notable significant difference in the early phase, particularly during the first 3 months. The amlodipine group demonstrated a more rapid blood pressure decrease compared to valsartan group. If we look at the right panel, which summarizes the difference in systolic blood pressure along with the odds ratio for the primary endpoint at each time interval, we can see a critical trend. In the first 0 to 3 months, the difference in systolic blood pressure was the largest, 3.8. And importantly, the period showed a significant difference in cardiovascular events favoring amlodipine group. This finding suggests that the early blood pressure reduction is crucial. It's not just average blood pressure over the course of a study. It's a matter about how quickly we can bring the blood pressure down, especially in the first few months. Rapid initial control blood pressure appear to be play a key role in reducing cardiovascular risk. Therefore, when considering antihypertensive therapy, are effective should be a key factor in regimen selection, not just the long-term target blood pressure. I included several guidelines for recommendation of initial antihypertensive therapy. First, in AHA guideline, 2 combination therapy is recommended in relatively moderate hypertension. I'm sorry for the slide is a little bit busy. In ESH guideline, initial monotherapy is recommended in specific patient, which is mild hypertension, frailty, older age, and high frailty. In other words, this guideline recommends that low-dose combination therapy as an initial therapy should be studied in most hypertension patients. This slide shows is our guideline. Japanese guideline is still conservative compared to other guideline. Grade 1 hypertension non-complication, the patient, we started the monotherapy, low-dose monotherapy. In addition, even in grade 2 or 3 hypertension and grade 1 hypertension with high risk, the guideline also recommended the standard dose monotherapy. Several years ago, the interesting quartet trial was reported. The aim of this study is to investigate which low-dose quadruple or standard monotherapy provides a benefit of blood pressure reduction. The primary endpoint is a changing in systolic blood pressure, office systolic blood pressure at 12 weeks. This slide shows a summary of the result of this study. Concerning SBP at 12 weeks, the SBP quadruple group was lower than that of the monotherapy group. The control rate was higher in the quadruple group than monotherapy group. On the other hand, adverse event was comparable between groups. Next, this slide summarizes a meta-analysis of 36 randomized controlled trials involving 44,000 participants focusing on initial and antihypertensive strategies. Quarter dose monotherapy lowered SBP by 4.7 millimeter mercury with minimal adverse event similar to placebo. Half dose combination and quarter dose combination both reduced by similar SBP reduction. Full dose monotherapy was more effective with lower SBP, but was associated with more adverse event, such as dizziness and so on. Most notably, the quarter dose for drug combination resulting in a substantial SBP reduction, 22.4 millimeter mercury, with a high likelihood of blood pressure control and no serious adverse event. These findings support the use of low-dose combination therapy as an effective and well-tolerated initial treatment approach for hypertension. To summarize today's talk, starting hypertension treatment with a low-dose single pill combination can offer rapid and safe blood pressure controls. This single pill combination-based strategy not only helps in achieving target blood pressure efficiently, but also improve patient adherence and long-term blood pressure control. In Japan, the triple drug single pill combination therapy, combination drug, are already available in clinical practice. But its use is not spread because there is a regulation. As such, concept of multiple low-dose agent in a single pill may very well become the new standard for initial hypertension management in the future. However, there are several challenge problems for low-dose triple or quadruple combination hypertensive therapy. First, these ultra-dose single pill combinations are not yet widely available. In many regions, these combinations either not approved or not reimbursed by insurance, limiting access for clinician and patient. Second, the issue of dose flexibility. Because all component drugs are fixed in dose, it becomes difficult to adjust for side effect on suboptimal response. For example, if a patient developed, we often experience peripheral edema from CCB. So if we use a CCB component, the physician cannot reduce just that one agent, CCB. Third, we still lack long-term data on heart cardiovascular outcome. While blood pressure lowering is a good surrogate marker, we need evidence for stroke or myocardial infarction and cardiovascular event especially in vulnerable populations such as elderly or those with comorbidities such as diabetes or CKD. Both ultra-low combination may not be potent enough for patients with elevated blood pressure. Therefore, while ultra-low dose single pill combination therapy holds promise, we need to carefully evaluate these limitations when considering them for routine practice. Thank you for your attention.
Thank you for Professor Hoshidai's excellent talk. And I think that you also provide a very comprehensive data from Japan that to show that the effectiveness, the efficacy of the quadruple therapy with a single pill to improve the blood pressure controls in Japan. And is there any comments from the floor or from the chairperson, Professor Uno?
Thank you very much. And I'd like to ask one question. And what is the major cause of the existence of the patient who are treated but uncontrolled? Do we need to simplify the medication?
I think there is several problems, but the most important problem is the term is clinical inertia.
Oh.
Patient and physician both. For example, and when we see physician see the patient, and physician called under the clinic, and we measure blood pressure about 140, 180. That's also okay. So, but and sometimes we recommend the increase the number of drug to the patient, but patient no. Yes, so the clinical inertia is most problem for the management hypertension.
Okay, and can I ask one more question?
Yeah,
Okay.
sure.
And, yeah, I think the Japanese JSH guideline will be changed this autumn.
Yes.
And do you think the treatment procedure for hypertension similar in the new guidelines?
I think I'm also the member of the guideline writing, but basically the basic strategies is almost similar.
Okay, thank you. Thank you. And I think that today, Professor, according to the talk of the Professor Reg, you also provide some strategies regarding to the polypill treatment. And Professor Reg, do you have any comments regarding to Professor Hoshidai's talk?
I think that was a wonderful presentation. But as I said, that there are differences in control of blood pressure region-wise. As taking cholesterol in our region, when I give any pill to control statin, patient is very well and within 4 to 6 weeks. But I have seen in European countries that say that when for 6 months treatment is given, then they reduce to mild levels. So there are same in the blood pressure levels. Japan is a very industrialized country. But in Pakistan, there are a lot of socio-economic problems, and the main reason in our region is the compliance and adherence to the medication.
Okay. Okay. So and I also want to raise one question, and I think that is interesting based on your speech, because we can notice that all over the world we can notice that the treatment rate and the well control rate was better in female than that in male gender. And can you do some explanation about this phenomenon? And is there any good strategies to improve the treatment and control rate in male gender? Thank you.
Yeah, I have clearly no idea about the sex differences.
One of the attendee participant here is Professor Khalda Sumro from Pakistan. She is coordinator of GORID of Pakistan, and she has worked a lot over the blood pressure, especially in the females. So, Madam Khalda, if you're listening, can you comment to this question? Please unmute, madam.
Oh, you are mute. Sorry, Professor Sumo. Oh, sorry, you are still muted. Yeah.
Repeat your question, please.
Question is asked that what is the difference between control of blood pressure in males and females? Because you have been working a lot on female lady blood pressure throughout the world and especially in Pakistan. Would you like to comment?
Yes, I would like to comment. In our country, majority of the population is having low education and residing in the rural areas. So there is poor control of hypertension in the rural areas, and non-compliance of drugs over there is more than the urban areas. So it is necessary to educate them, and we are doing our best from the Pakistan Cardiac Society, GORID for Women, and the Scientific Council of the Women with Heart Diseases to educate our rural area women by our messages, by our television programs, by our small symposia and from the Pakistan Hypertension League, small symposium and the screening of the hypertensive patient in our rural area. So hopefully within a few years, we will achieve our targets and control the blood pressure and its complications, not only in the urban areas, but in the rural areas as well. Thank you so much.
Okay, thank you for your comment. Yeah.
Definitely, there is a difference in between the control of hypertension in women and men, because the women are having less access to the rural area health sectors, and they, as they are dependent on the male population. So due to the economical problem, they have less hypertension, less drugs. They are not taking them properly, and caregiving. Caregiving is another problem. Not only they are giving care to their own children, but a combined family system. They are offering care to whole family, and naturally they are under stress, and they are having less compliance of the drugs, and we are not at present achieving our goals. And pregnancy-induced hypertension is again a major problem due to the non-compliance of drugs and the treatment. Awareness what treatment should be given during the pregnancy to a woman patient, and about the side effects by the local doctors. So we have to be careful. Dr. Rajkumar will further highlight this.
Okay, thank you. Thank you for your feedback. And I think that maybe some poor compliance in male gender and the poor social economic support may be one of the potential reasons for the worst compliance, for the worst control rate in male genders. And I think that this topic deserves further research in the future. And I think I have one last question for Professor Hashudai. And I think that do you think the 4-in-1 single pill combination suitable for the upfront to the upfront first-line strategies for all the patients, or which kind of patient is the most appropriate group for this kind of strategy? Thank you.
Okay, thank you very much. The most suitable patient is for the quickly or rapid blood pressure reduction is the need of rapid blood pressure reduction. For example, for the patient with high risk patient for cardiovascular events. So as I said, that the clinical inertia is important. So if the initial early reduction will be achieved, we don't need to concern the clinical inertia. So therefore, the combination therapy is important for the management of hypertension treatment. Thank you.
Thank you. Any other questions? Okay. If there's no more questions, I would like to invite Professor Uno to chair the next three speakers. Thank you.
Okay, thank you very much. And the next speaker is Dr. Yu-Chen Wang, and he is an associate professor from the Department of Medical Laboratory Science and Biotechnology, AJ University. And he's also the director of the Internal Medicine Department and director of Cardiology Division, AJ University Hospital. And the title of his talk is Causal and Cumulative Effect of Atherogenic Lipids on Lifetime Risk of ASCVD and Timing of Lipid-Lowering Therapy. Never too early, never too late. Dr. Wang, please.
Thank you. Thank you for your kind chair. And can you see my slide?
Yes, but it's
okay.
not. Okay, yeah.
Okay, thank you. Good afternoon. I'm Yu-Chen Wang from AJ University Hospital in Taiwan. And today I would like to explain why the lifelong exposure to the atherogenic lipid drives the cardiovascular event, and why we said never too early, never too late for the lipid-lowering therapies. And it's my outline of my talk today. First of all, I would like to echo to the topic, never too early. I would like to address the importance of the early LDL cholesterol controls for primary prevention population. And when we talk to the lifelong exposure to the LDL cholesterol, I think the concept is just like we save the money to our bank account. However, from this point of view, we actually save the cholesterol, LDL cholesterol to our coronary plaque. And therefore, as time goes by, if you have a higher cholesterol level with a longer exposure, the plaque burden will be increasing gradually. Therefore, we can say that both the magnitude and duration of the LDL cholesterol exposure have the high impact to the cardiovascular risk. And we can see that both the LDL cholesterol level and the ApoB level start to rise at the early 20 to 30 years, both in male and females. And we can also see that the lifelong LDL exposures lead to the accumulation of the coronary, of the calcium accumulation in our coronary arteries on the CT scan. And we also know that the increased calcium score was correlated directly to the increased ASCVD risk. And we can also see that even with the average LDL cholesterol levels, just as the 125, but if we can live to as old as 80s, the lifelong ASCVD risk was still higher than 20%. However, if we can lower our LDL cholesterol levels by 50% since the age of 40, the lifelong ASCVD risk can be lowered to less than 5% in this way. And we can also see that if we can start our lipid-lowering therapy at a younger age, we can get greater CV risk reduction compared to the no treatment group. And we can see that from the right side, we can see that even with the moderate LDL cholesterol lowering to 36% at the age of 40, we can reduce our CV risk from 23% to 10% at the age of 80. However, comparing to the result of the statins randomized control trials, we can see that in the Mendelian randomization studies, even with the similar LDL cholesterol reduction levels, we can get a greater CV risk reductions in the Mendelian randomization studies. And I think that that's the most important difference between the Mendelian randomization study and the statin RCT is the lifetime benefit. That means in the Mendelian randomization studies, with a lifelong LDL lowering, with a lifelong lower LDL exposure, even with the same LDL cholesterol levels, you can still get better or higher CV risk reduction comparing to the statins randomized control trials. And because we know that in the RCTs, most people receive the statin treatment only for 3 to 5 years. And therefore, longer LDL lowering can result in greater CV risk reduction in this way. And similarly, if we can start to lower our LDL cholesterol levels from 125 to 80 at the early age in our life, we may delay the potential MI attack age from the 60s to 100-year-old. So I think that it may be a dream for every cardiologist. Then I would like to move to the next section, the never to echo the word never too late. I would like to address the importance of the rapid LDL cholesterol lowering after the cardiovascular events. And there's the common myth that many patients will think that if they get the AMI or stroke, it seems that it's an end point. Everything's over, and there's nothing we can do anymore, just like a terminal cancer. However, is this true? Is this true? Is this a really endpoint? Of course not, because that the story is not end. We know that it's not the endpoint. Even after we get the acute myocardial infarction, we know that with the advancement of the novel PCI technique and the pharmacotherapy, most of patients can survive even getting the AMI attack. However, since these patients can survive during the index event, so there will be some substantial recurrent CV events as time goes by. According to the REACH studies, we can clearly see that the recurrence rate risk during the first year after MI was 4.7%, and the recurrent MI risk at the second, third, and fourth years was range from 3.4 to 3.6%. And therefore, we can say that the story is still keeps going even after you got the index MI attack. And in Taiwan, we also can see some our local data that after getting the first MI, there is still substantial recurrent MI at the time after 7 years of clinical follow-up. And however, according to the data from mainland China, we can also see that the rate of recurrent MI during the first year was up to 2.5%, and 36% of these patients attacked at the first month after MI. And we can see that in this study, the early recurrent MI during the first year was associated with the highest 1-year mortality rate, which was as high as 53% in these studies. And we know that when we try to do the deep dive to the underlying pathophysiology perspective to see what drives the recurrence of the acute myocardial infarction. I think that one of the most important is the vulnerable plaque, because we know that in ACS population there will be many vulnerable plaque all over our coronary artery trees, and the feature of the coronary vulnerable plaque includes the greater lipid burden, thinner fibrous cap, and more thrombus formation by the IVAS or OCT images. And I think that the appearance is just like the famous Chinese food, the xiaolongbao, or the steamed soup dumpling. It is well known with the thin wrapper, and contains a lot of flavor, juicy flavors inside, and a lot of meat inside, juicy meat inside. So I think that the vulnerable plate is just like this one, and it is easy to be ruptured and to have some thrombus formation. And according to the IBUS and the nearest studies, and when we look into the patient after myocardial infarction, we can surprisingly to see that most of the recurrent MACE comes from the originally non-calculable lesions instead of the calculable lesions. And we can also recognize that the acute myocardial infarction is actually indeed a systemic disease rather than a local one. And in this patient with ACS population with ACS, we can see the calculable lesion lies on the mid LOD bifurcation. However, we can also see some volume plaque with some microthrombi formation in the moderate stenotic OM branch. And in this study, 79% of acute ACS patients had at least one plaque rupture found at sites other than the calculable lesions. So I think that in ACS population, what we can do is not only to stent in the calculable lesion, but we have to reduce the inflammatory burden to reduce the vulnerability of the plaque in our coronary artery to reduce the CV risk. And one of the most important factors to induce the plaque rupture is the LDL cholesterol level. It is well known that the LDL cholesterol level, LDL cholesterol, not only lead to the endothelium disruption, lead to the plaque rupture, but it also prevent the plaque to heal properly. Therefore, the delayed endothelium healing will lead to the recurrent CV event in patients suffering from acute myocardial infarction. This kind of findings justify the strategies to lower the LDL cholesterol level in a very aggressive way. And so we know that it is very important to lower our LDL cholesterol level to a very low level to stabilize our vulnerable plaque, to make them from vulnerable plaque to the stable plaque to reduce the recurrent CV events. And according to the IBUS and OCT studies, we can clearly see that if we can lower the LDL levels to a very low level and not low levels, the plaque burden will decrease if the LDL cholesterol levels is less than 70. And besides, according to the data from OCT, if we can with the LDL cholesterol lowering, the thickness of the fibrous capsule will increase in the directly. It means that the LDL cholesterol lowering can lead to the increased fibrous cap thickness and to stabilize the plaque and change the plaque from vulnerable one to the stable one. And there are many statins randomized control trials focused on ACS population, which shows the time-related benefit in this population. And all of these studies clearly show that if we can prescribe our lipid lowering therapies as soon as possible, it will lead to the reduced risk of the 30 days MI, 30 days MACE, and 30 days MACC rate in ACS population. And in Japan, there is also a very important randomized control trial, the ASCVD OCT study, which enrolled 70 ACS population and randomized them into the early and late groups. The early group received the pitavastatin 4 mg per day immediately after the index PCI, and the late groups received the statin therapy 3 weeks later. And the OCT was conducted at the baseline index PCI 3 weeks later and 6 months later. And the representative figures in this study show that in the early group, the fibrous cap thickness continues to increase at 3 weeks and 6 months. However, in contrast, in the late group, we can see that in the 3 weeks, the 3 weeks OCT show that the thickness of the fibrous capsule not only didn't increase, but even decreased with some endothelium disruption and microthrombosis formation. It means that the delayed statin prescriptions lead to the plaque instability and lead to the microthrombosis formation, which may lead to the recurrent CV events. And after 3 weeks, after the statin prescriptions, the fibrocap thickness eventually increased at the 6-month follow-up. However, in the later statin group, at the 6-month follow-up, the increment of the fibrous capsule was still lesser compared to the early group. And the finding of these studies address the importance of the early statin treatment after the ACS. And similarly, according to the retrospective data from Asa Medical Center in South Korea, it tried to evaluate the cardiovascular outcomes of early LDL goal achievement in patients with very high risk ASCVD. And in this study, patients who receive who get the LDL cholesterol levels to less than 55 at the window of 4 to 12 weeks after the index discharge was defined as the early achiever, and all the other ones were classified as the non-earlier achievers. And in this study, we can clearly see that the early LDL goal achievement at the window from 4 to 12 weeks after the index discharge was associated with lower recurrent MACE rate in these ASCVD patients. And this study also showed that the early LDL goal achievement was also associated with reduced health resource usage, which includes the CV-related hospitalization and reduce the length of stay of the CV hospitalization. And similarly, there is also another important retrospective data from Asa Medical Centers, which found that the early ezetimibe patients with early ezetimibe treatment, which was defined that the adding on of the ezetimibe to statin within 12 weeks during the index hospitalization. And the early ezetimibe group was associated with improved MACE rate compared to the late ezetimibe groups and the patient with no ezetimibe. And in this study, it is also very clear to see the proportion of patients to achieve the LDL targets to less than 55 is the highest in the early ezetimibe group compared with the late ezetimibe and the no ezetimibe group. However, since we know that it's very important to get the LDL target in the high-risk groups, however, in real world, we also know that the LDL goal are very difficult to reach. In Taiwan, according to the T-SPARKLE registries from 2010 to 2014, in ASCVD patients, 43% failed to achieve the LDL target as a goal to less than 100. And in the DICES-2 studies, in the East Asian ACEs populations from 2013 to 2014, we also found that 55% of patients failed to achieve the LDL target to less than 70. And the low LDL achievement rate is not only the problems in East Asian, but it's also a global problem. According to the data from Europe, United States, and India, the average LDL goal achievement to less than 55 was only as low as 20 to 22%. And regarding to the factors affecting the LDL goal achievement, there are some factors related to the patients, related to physicians, and related to the health reimbursement system. And however, I think that one of the most important challenges while using the high intensity statin is the statin side effect or the statin's intolerance. And one of the studies showed that if you in the high risk ASCVD patients, if the patients discontinues to use the statins within 6 months, it will lead to the higher risk of myocardial infarction or cardiovascular death. And so we can say that it's never too late to lower the LDL cholesterol levels after the cardiovascular event, and we know that the timely intervention can still make a meaningful difference. And then finally, let me summarize some of the current recommendations from clinical guidelines. And first of all, let's see the guidelines for the primary prevention lipid control. In Taiwan, the 2022 lipid guidelines for primary prevention just classified our patients according to the clinical risk factors. And patients in this guideline, patients with diabetes, CKD, or LDL cholesterol levels higher than 190 was classified as the higher risk. And other patients without diabetes, CKD, or LDL cholesterol level higher than 190 was classified as a moderate, low, or minimal risk groups according to the number of the clinical risk factors. The clinical risk factors in this guideline include the hypertension, low HDL cholesterol level, high age, family history of premature CAD, smoking, or metabolic syndrome. Totally speaking, if patients with 2 or higher than 2 risk factors were classified as a moderate risk. Patients with only 1 risk factor were classified as a low risk, and patients with zero risk factors were classified as a minimal risk. And in this guideline, patients with high risk, including diabetes, CKD, or LDL higher than 190, the target was to lower the LDL cholesterol level to less than 100. Otherwise, the LDL target for the moderate, low, and the minimal risk groups were less than 115, 130, and 160, respectively. And then let's take a look into the guidelines for the secondary prevention lipid control. In 2022, Taiwan lipid guidelines focus on CAD, PAD, or stroke, and this guideline emphasize on the extremely high risk population. This means the patients with CAD or acute coronary syndrome with other additional risk factors such as diabetes, recent MI within 1 year, multiple myocardial infarctions within the past 2 years, multivessel CAD, or concomitant PAD. In these extremely high risk groups, the LDL target was recommended to lower to less than 55. And in this guideline, both the moderate to high intensity statin monotherapy or upfront combination therapy with moderate intensity statin plus ezetimibe were recommended for the effective LDL lowering. And similarly, in the 2023 Taiwan CSIS guideline, it also endorsed the concept of including the earlier the better, the lower the better, and the longer the better. And it also endorsed the upfront combination therapy of statin with non-statin agents in CSIS patients at extremely high risk. And in 2023 ESC ACES guideline, it also emphasized on the importance to lower the LDL cholesterol levels to less than 55 and to reduce the LDL cholesterol level by more than 50% from baseline in high risk groups. And we can in this guideline, it also emphasized on the importance of the timely LDL lowering intensification within 4 to 6 weeks if the target was not achieved. In this guideline, we can see we should follow up the lipid profile within 4 to 6 weeks, and if the target was not achieved, ezetimibe or even PCSK9 inhibitors were recommended for the LDL goal treatment. And similarly, according to latest 2025 ACCHA guidelines update, it also emphasized to reassess the lipid profile within 4 to 8 weeks after discharge and to adjust the therapy as needed to achieve the desired lipid target. And finally, in Taiwan, we have just published the 2025 consensus on the clinical pathway of the blood cholesterol management in Taiwan. And in this guideline, we also focus on the time to intensify the LDL treatment intensification in a timely manner. In low or moderate risk groups, the LDL target, we should follow up the lipid profile at 3 to 6 months after prescribed statins. And otherwise, in the high risk groups or in the secondary prevention groups, we should follow up our lipid profile after 6 to 8 weeks to intensify our lipid-lowering therapy if necessary. In this way, we believe that we can improve our patient outcomes in a timely manner. Therefore, regarding to the take-home messages, first, never too early. Early LDL cholesterol control for primary prevention is critical, and starting earlier leads to greater long-term CV outcomes. Second, never too late. Even after cardiovascular events, achieving rapid lipid control still provides significant benefit and improves the patient's outcomes. And finally, consistent and intensive lipid-lowering therapy following a guidelines recommendation remains the key to lowering the ASCVD risk throughout our life. Thank you for your attention.
Thank you very much. Dr. Wang did an excellent job summarizing methods for controlling blood lipid levels. And also he introduced us the guidelines for the treatment of the lipid lowering in Taiwan. And yeah, there is one question from Professor Solomo. And the question is, how about the considering of those adjustments of statin according to the BMI?
Okay, I think that it's a very interesting question because that according to previous guidelines, we didn't recommend it to adjust the statin or lipid-lowering therapy dosage according to BMI. Instead, I think that the basis to adjust the lipid-lowering therapy or not based on the result. That means the LDL cholesterol levels. Therefore, we can see that according to the latest guidelines, we should follow up the lipid profile in a timely manner, for example, within the 6 to 8 weeks or within several months to see if the LDL cholesterol level is to achieve the target. If not achieved, I think that we should increase the statin dosage or add on another non-statin agent. But I have no. I don't think that BMI is one of the factors I am concerning when I think if I should adjust the lipid-lowering therapy or not. Thank you.
Okay, and I'd like to ask you several questions. First, you explained the guidelines in your country, and for the patients with ACS with high risk, you said that the LDL should be lowered than 55 milligram per deciliter. And but that may be depend on the result of the Fourier with
maybe ODC study, maybe ODC study, yeah.
Yeah, but in Asian people, that level is not proved yet. And do you think do you think we should lower the LDL level, lower 55 even in Asian people?
Oh, okay. I think that thank you for your very important question. I think that from some perspective, for example, from the antiplatelet therapy or the antithrombotic therapy, I think that there may be some racial difference between Eastern and Western populations, because we know that in Japan you have many important studies to show that in Japanese populations, lower dose of antiplatelet P2Y12 inhibitors, for example, the prasugrel or the rivaroxaban, can lead to similar platelet function inhibition or the antithrombotic effect. Comparing to the Caucasian. Therefore, in East Asian population, to prevent the bleeding events, right now some low dose blood sugar, reduced dose were available both in Taiwan and in Japan, and low dose rivaroxaban, for example, rivaroxaban 15 milligrams per day was also well accepted in Japan or in East Asian countries. However, I think that regarding to the issues of the LDL lowering, first of all, I think that there's no evidence to show that extremely low LDL levels will do some harmful effect in Asian population or in patients with low BMI. Right now, according to the data from East Asian or from West Caucasian populations, the data were consistent to show that the LDL, the relationship between the LDL cholesterol level and the ASCVD risk was the lower the better, both in East Asian and in Caucasian populations. Even though in most randomized control trials, the data come from Caucasian. In Japan, I think that there were two important randomized control trials, the TST study and the real CAD study. And in these two studies, in real CAD, the high intensity pitabastatin, high dose pitabastatin, 4 milligram can lead to the better clinical outcomes when the LDL cholesterol level will be reduced to less than 70. And in TST studies, for stroke patients, similarly, if the LDL target can be achieved to less than 70, better clinical outcomes can be shown. However, in the RCT trial, we don't in the East Asian population, we don't have the target-driven studies to show that the LDL cholesterol levels less than 55 is beneficial comparing to targets, for example, 70 or 100. However, I think that according to the epidemiology data or the real-world data, for example, the registry data or the retrospective data, we can still also see that lower LDL cholesterol level is still beneficial in East Asian population. So I think that in extremely high-risk patients, to lower the LDL cholesterol level to less than 55, I think is reasonable even in East Asian population.
Okay, thank you very much. And are there any questions or comments from the speakers?
Hello.
No. Okay. Go ahead.
Dr. Chan Wang, very nice presentation. It was a detailed talk on the statins. Of course, everyone will agree that lower is better. But let me ask you that, have you tried PCSK9 drugs in any patient? And second thing, what do you do in a statin-resistant patient who are high risk for atherosclerotic cardiovascular disease?
Okay, regarding to the first question, yes, in Taiwan, we did have some experience to utilize the PCSK9 inhibitor in extremely high risk patients. For example, in the FH, familial hyperlipidemia patients, or in high risk patients who cannot achieve the LDL target. For example, in ACS populations, the LDL cholesterol is still higher than 100 or 135. Even with the maximal tolerated statin with ezetimibe. In this kind of patients, we will prescribe the PCSK9 inhibitor. However, I think that in Taiwan, the major limitation to use the PCSK9 inhibitors is still the cost, because that is very expensive even in Taiwan, so that we have very strict regulation or limitations by our health reimbursement. For example, in Taiwan, for ACS population, the reimbursement criteria is higher than the LDL cholesterol level higher than 135 under the maximal dose of statin with ezetimibe. But I think that most of the patients cannot fulfill this kind of criteria. So I think that in this way, we have to persuade our patients to pay by themselves. However, I think that the economic condition is also the major limitation for the widespread use of the PCSK9 inhibitors. So I think that is still the major limitation because of the cost. And then apart of what about the second question?
statin-resistant patients.
Uh,
High-risk patients who are resistant to the statins. They cannot tolerate statins. Are you getting me?
No, I cannot get. Yeah.
There are certain patients who cannot tolerate the statins.
Oh, okay. In Taiwan, for the patient who cannot tolerate the statins, there is some regulation to cover the PCSK9 inhibitors in this kind of patient. However, we have to apply in advance and to write down a very detailed information, to write down the reasons and to record our previous trial, to try every kind of statins in this kind of patient, and to record the side effect of the patient. For example, the myalgia, even the rhabdomyolysis or the hepatic dysfunction, something like that, to show our confidence that the patient, this very high risk patient cannot tolerate the statin. So in this way, they will allow you to use the PCSK9 inhibitors by the health reimbursement. But I think that the regulation is still very strict. So sometimes we can still not use the PCSK9 inhibitors for every statin intolerant patient in Taiwan. I still think that the cost is the major limitation in this way.
No, I'm sorry that I do not agree with, because those patients who are having huge side effect profile, naturally you can't use the statins on those patients. So what is the option that if the patient is not tolerating or producing side effects with the statins, naturally you can't continue them?
Okay, in Taiwan right now, if the patient cannot continue tolerate the statin, I think that ezetimibe is still another choice. But however, ezetimibe it just provide a very low to moderate efficacy to lower the LDL cholesterol levels. So I think that is still some restrictions even in Taiwan. Yeah.
What about
I think that
bempedoic acid?
Yeah, bempedoic acid. Yeah, right now we start to have the bempedoic acid right now, but not it's still not totally available in every hospital in Taiwan, because we start to have the bempedoic acid. But by myself, I still don't have experience to use the bempedoic acid. But I think that is another solution, a potential solution for the statin intolerant patient. But in Taiwan, it's still not covered by the health reimbursement. So patients still have to pay by themselves.
Okay, time is up, and we would like to move on to the next speaker. Thank you very much, Dr. Wan.
Thank you.
And then I'd like to introduce the next speaker. He is Dr. Weerapan Hunkit. I'm sorry, I cannot correct the pronunciation of your name, but he's a professor of medicine, head endocrine and metabolic disorders research unit, the Faculty of Medicine, Chulalongkorn University, Bangkok, Thailand. And the title of his talk is Role of Lipoprotein small a elevation to long-term risk of subclinical ASCVD and MACE of clinical ASCVD. Any difference between Westerners and Orientals?
Thank you very much, Professor Ono. Let me share my slide. You see it in full screen now?
Yeah, go ahead, please.
Thank you. So my name is Weerapan Chunkit. I'm from Chulalongkorn University in Thailand. I'm actually not a cardiologist, I'm an endocrinologist. So the part of my talk, I will start with the brief introduction on Lp(a), talk about the molecular structure and genetic determinants, and then briefly tell you about the ethnic differences in Lp(a) levels. And then I will talk about the studies on Lp(a) levels and both subclinical and clinical ASCVD. Is there any difference between Westerners and orientals, and I will end with the current guidelines and recommendations. So what is Lp(a)? It's an LDL-like lipoprotein particle. It contains ApoB connected to a unique plasminogen-like protein called Apo(a). We know that elevated Lp(a) level is an under-recognized genetic cardiovascular risk factors that affected about 1 in 5 people. So worldwide, more than 1.4 billion people with elevated Lp(a) are at increased risk of ASCVD. And currently, clinical trials of various Lp(a) lowering drugs are underway, and they have potentials to reduce the risk of ASCVD. Apo(a) is a unique protein that has arisen from the plasminogen gene, and that was further duplicated and modified. It contains characteristic loop-like structures that resemble what we call kringles. Kringle, this word came from a Danish pastry. The kringle has 3 internal disulfide bonds, and these kringle domains are usually found in several coagulation factors, including plasminogen. If you look at the structure of plasminogen, you can see that it has 5 kringle domains and also 1 protease domain at the end. So Apo(a) is evolved from the plasminogen gene, and during evolution, the kringle 1, 2, and 3 domains were lost by deletion. The kringle 4 domain were expanded and differentiated into 10 different subtypes of kringle 4, and we call that kringle 4.1, kringle 4.2, kringle 4.3 until kringle 4.10. Further, the kringle 4 type 2 domains were expanded into multiple copies, which lead to a size polymorphism of Apo(a) ranging from 300 to 800 kilodalton. And at the end, the protease domain has no fibrinolytic activity, and therefore it has been hypothesized that Apo(a) may actually compete with plasminogen, therefore inhibiting fibrinolysis and increasing thrombosis risk. What is the physiological function of Lp(a)? It remains a mystery. Has been proposed to be involved in fibrinolysis, has been proposed to be involved in wound healing and tissue repair. We know that Lp(a) could be an acute phase protein because during inflammation and infection, Lp(a) levels are increased. Also, Lp(a) is the main carrier of oxidized phospholipids in the plasma. Interestingly enough, there are people from the Northern European population who have loss of function mutations in Apo(a) gene, leading to minimal or undetectable levels of Apo(a) in the blood, and they seem to be healthy with no clinical signs or health deficits. As I mentioned earlier, Lp(a) is a main carrier of oxidized phospholipids, and these oxidized phospholipids may be the main atherogenic component of Lp(a) because they can induce inflammatory responses through different receptors on monocytes and macrophages. Therefore, the Lp(a) particle has been shown to be pro-atherogenic because of its cholesterol content, and also pro-inflammatory because of it contains oxidized phospholipids that could drive inflammatory response. In addition, it could be pro-thrombotic because of the Apo(a) component. The levels of Lp(a) varies by a factor of 1,000, ranging from less than 0.1 milligram per deciliter to more than 300 milligram per deciliter. In the general population, Lp(a) levels are highly skewed to the right. These data are from the Copenhagen study in the white populations, and it has been shown that about 2/3 of the general population have Lp(a) levels in the low cardiovascular risk. but about 20% or 1 in 5 people have levels associated with increased cardiovascular risk. In women, they tend to have higher Lp(a) levels than in men, about 5 to 10% higher. And it should be noted that Lp(a) levels are stable throughout life, and whether or not you modify your lifestyles, they remain unchanged. We know for quite a while that Lp(a) levels are different among various ethnicities. Majority of the Lp(a) levels is determined by the genetic variants at the Lp(a) locus, which encodes for apolipoA. The main site is in the Kringle4 type 2 repeat polymorphism, which explain the majority of the variability in Lp(a) level, and that determines the apolipoA size as well. So in brief, the primary determinant of differences in Lp(a) levels is due to differences in apoA isoform size. If you can see in this picture, this particle has 4 repeats of the Kringle4 type 2. This particle 8 repeats of Kringle4 type 2, and this particle 24 repeats, and this particle has 40 repeats of Kringle4 type 2. So the size of this apoA isoform is inversely associated with plasma Lp(a). So the fewer the isoform size, the higher your plasma levels of Lp(a) is. When you have a low number, for example, less than 22 copies of Kringle4 type 2, you have higher Lp(a) because you have small isoforms and your liver can produce apoA much faster. But when you have large isoforms, for example, more than 22 copies, these large isoforms are more susceptible to be degraded in the endoplasmic reticulum, and that results in 4 to 5 times lower of Lp(a) compared to the low number of Kringle4 type 2 repeats. However, it should be noted that there is a wide variability in Lp(a) even among those who have the same Kringle4 type 2 repeats. For example, if you have 20 to 22 copies of the Kringle4 repeats, your Lp(a) levels can range from 20 up to about 160. As I mentioned earlier, there are ratio variations in Lp(a) levels, and that was in part due to differences in Kringle4 type 2 repeats. In our East Asian populations, we tend to have a higher frequency of a high number of Kringle4 type 2 repeats, and that translated to a low levels of Lp(a). For the African population, they have a high frequency of low copy numbers, and that's translated into higher levels of Lp(a). This graph shows distribution of Lp(a) levels in different ethnic groups. I've shown you earlier, this is the white population for the Northern European. In the Chinese population, looks similar like the white populations. But for the Black population, the distribution seems to be in the normal distribution, unlike the white and the Chinese population, which are skewed to the right. Epidemiological studies from the Copenhagen study show that high Lp(a) levels are causally associated with acute myocardial infarction and also aortic valvular stenosis. This is a hazard ratio when you have a doubling in Lp(a) levels. Also, if you have 100 nanomoles per liter higher of Lp(a) levels, your hazard ratio would be increased. If you have a higher number of Lp(a) increasing variants, then you have a higher hazard ratio for major cardiovascular events as well. Later data from UK Biobank also confirmed the data from the Copenhagen study that high Lp(a) levels are causally associated with MI and aortic valvular stenosis, but also other forms of ASCVD, including ischemic stroke and also heart failure. It is interesting that the association seems to be continuous with no evidence of threshold. So these are the impact of elevated Lp(a). If you have high Lp(a), you are more at increased risk of acute myocardial infarction, calcific aortic valvular stenosis, heart failure, ischemic stroke, peripheral arterial disease, and also cardiovascular and all-cause mortality. What's the relationship between Lp(a) levels and subclinical ASCVD? Coronary artery calcium, or CAC, is a specific marker of subclinical coronary atherosclerosis. And we use that a lot because it's a guideline-endorsed predictor of ASCVD risk. Recently, there's a meta-analysis published which show that elevated Lp(a) was associated with a higher prevalence of CAC and also a greater progression of the CAC. This is a meta-analysis of 8 studies about almost 30,000 patients. They compare those with normal Lp(a) and elevated Lp(a). And the elevated Lp(a) was defined as more than 30, more than 50, or in a high quartile, depending on the study. However, it has been shown that you can see that the hazard ratio is 1.31, which is significant, although the heterogeneity is high. If we focus on the Asian subgroup, there are 4 studies, mainly from Korea, Indonesia, and South Asia. Again, you can see the hazard ratio is 1.28, similar to the overall cohort. But again, because of the lower number of subjects, it did not reach statistical significance. That's CAC prevalence. How about the CAC progression? There are 4 studies of 9,000 patients, which show that when you have elevated Lp(a), you have a higher odds ratio of CAC progression, and that remains significant. Just for the Asian populations, mainly from Korea, Japan, and South Asia countries, it was high, but did not reach statistical significance, probably due to a lower number of subjects. This is an interesting study derived from the MACCE multi-ethnic study of atherosclerosis and the Dallas Heart study, which show independent association of Lp(a) and the calcium score with ASCVD risk. If you look at the graph on the right-hand side, if you have calcium score less than 100, it doesn't matter whether you have high or low Lp(a), because your ASCVD risk is about the same. But if you have higher calcium score more than 100, then if you have high Lp(a) equals or more than 50 milligrams per deciliter, it could modify your risk to a higher risk. Well, how about the ASCVD or clinical ASCVD? What's the relationship between Lp(a), ASCVD, and is there any difference between Westerners and Orientals? There is a study, actually not a study, a scientific statement from the Chinese population, from the Beijing Heart Society on Lp(a) and cardiovascular disease in the Chinese population. In this statement, it stated that increased Lp(a) levels are independent risk factors for the Chinese populations for CAD, ischemic stroke, and also calcific aortic valvular stenosis. And based on the existing data from the Chinese population, they chose the cutoff values of 30 milligram per deciliter to indicate an increase in cardiovascular risk. I found a paper from Korea, the Samsung Health study, a large number of subjects. They follow up for a median of 6.6 years. They show that those people, those Korean populations who have high Lp(a) more than 50 milligram per deciliter, they have a 83% increase in cardiovascular death, 400% increase in MI death, 20% in all-cause death, but no increased risk in cancer death. And this is a predictor regardless of LDL cholesterol levels. There are also other studies that compare differences in association of Lp(a) and ASCVD risk between different race or ethnic groups. For example, the Dallas Heart Study, the MESA, NHANES, InterHeart, ERIC, and UK Biobank. I will not talk about all of them, just select some of the studies. This is from the MESA study. It showed that in the white population, Lp(a) levels are associated with a higher risk of ASCVD. Again, for the Chinese and the South Asian populations, this seems to resemble the data from the white populations, although it may not reach statistical significance because of the lower number of subjects. The largest subjects we have so far is from the UK Biobank. This is more than 400,000 subjects. And this is show the prevalence and incidence of the cardiovascular risk and its hazard ratio according to different ethnicities, the white, the South Asian, and also the Black populations. If you look at the hazard ratio, for every 50 nanomoles per liter increase, the hazard ratio in the white was 1.11, South Asian 1.10, and Black 1.07. They were relatively similar. And if you use different cutoff levels, for example, you use threshold of 150 nanomoles per liter, or you use the race-specific 90th percentile, you can see that the numbers are relatively similar according to different race or ethnic groups. So far, the evidence we have from the prospective and case control studies show that elevated Lp(a) levels are associated with ASCVD risk in all ethnic groups. Although Lp(a) levels are variable across racial subgroups, the relative risk appears to be similar. Therefore, the predictive value of Lp(a) doesn't vary sufficiently to mandate the use of ancestry-specific risk threshold. There is so far no evidence to establish a race-based definition of elevated Lp(a). So this is the levels that we use mainly from the EAS guidelines, less than 30 milligram per deciliter to indicate low risk, more than 50 milligram per deciliter to indicate high risk, and something in between to indicate intermediate risk. These are the guidelines from various societies indicating when to measure Lp(a). I will not talk about all this, but just to point out that the EAS or ESC guidelines recommend that all people at least should have Lp(a) level at least once in a lifetime. And that's to identify those who have high cardiovascular risk. For the Beijing Heart Society recommendations, they didn't recommend to screen all of them, just the population with high risk for ASCVD, family history of early onset ASCVD, relatives of those who have high Lp(a), FH, and also patients who have calcific aortic valvular stenosis. So in conclusion, elevated Lp(a) level is causally associated with ASCVD and calcific aortic valvular stenosis. Levels of Lp(a) are highly genetically determined and vary across different ethnicities. current evidence indicates that high Lp(a) are generally associated with ASCVD risk in all ethnic groups, but the relative risk appears to be similar. Therefore, screening for Lp(a) levels should be considered for all ethnicities, and further studies are necessary to determine whether ethnic-specific cutoff values should be developed and implemented in clinical practice. And for this, thank you very much for your attention.
Thank you very much, Dr. Kovit-Hunkit. He well summarized the structure and the function of Lp(a). And he also tried to show the difference between the East and the West. And there is one question from Professor Somoro. And the question is that, are there any hormonal impact in post-menopausal women on Lp(a) level and its impact on coronary artery diseases?
Yes, there is. Actually, it's been shown that women, when they undergo menopause, their Lp(a) levels will increase about 20%. So it is also recommended that in women, when they undergo menopause, they should have Lp(a) level repeated. Yes, and it came down with also hormone replacement therapy. But so far, we have no evidence that treatment with hormone therapy will decrease the cardiovascular risk. So it's not yet recommended to use hormone therapy to lower your Lp(a) levels.
Okay, thank you. And are there any questions from the speakers? How
Thank
about
you for
Juan?
yeah. Thank you. Thank you for your very informative talk. And I think that regarding to the examination of the lipoprotein (a), one of the major issues is that the unit right now we use is still not unified, because there we can see that nanomole per liter or milligram per deciliter. And according to your opinion, which one would you prefer, or do you think it's necessary to unify these two units in the future? Thank you.
Thank you. That's a very interesting question and important question as well, because we have problems when one lab reported the Lp(a) levels in milligram per deciliter and another lab reported in nanomoles per liter. Right now, I would say whatever you have, you use that lab, and usually the laboratory will report it according to the assay that was performed, and the calibrator would comes in either milligram per deciliter or nanomoles per liter. So if the labs use the nanomoles per liter as a calibrator, then the report should be in nanomoles per liter. But if the lab used the milligram per deciliter for the calibrator, then the result should come out as milligram per deciliter. Right now, there is no consensus yet how to convert from milligram per deciliter to nanomoles per liter. But there is an increased need to unify all this. And I think it's underway because we recognize that this is an important problem worldwide.
Thank you.
Thank you.
Okay, I'd like to ask you one question. And currently, we still don't have an effective drug to reduce the Lp(a) levels.
Right.
What should we do for the patients with high Lp(a)?
Yes, that's another important question. When we encounter a patient with high Lp(a), we don't yet have therapy to lower that. But what I would recommend is to look at the overall ASCVD risk in that subjects and try to lower their overall risk. Check their blood pressure, check their diabetes, also lower your LDL cholesterol levels, stop smoking, more exercise, lower all ASCVD risk, because there is some data showing that in people who have high Lp(a), if they lower their LDL cholesterol levels lower enough, their risk of ASCVD would be lower. And that would be my recommendation. another recommendation for that subject is to cascade screening for their family members, because we know that it's genetic. Thank you.
Okay, thank you very much. And are there any questions from the speakers? Okay, time is up. Thank you very much, Dr. Kovitunkit. And we'd like to move to the last speaker. The last speaker is the Dr. Victor Joseph. He's head of cardiovascular prevention and rehabilitation department. And okay. And the title of his talk is "A Smoking Paradox Exists or Not After Percutaneous DES or Surgical Coronary Revascularization. Decade Cooperation Shows." Dr. Joseph, please.
Okay, thank you for the opportunity that has been given to me. Let me introduce myself. I came from, not from Jakarta, the city that you have known well. I came from eastern part of Indonesia. It's about 3.5 hours flight. Okay. Now I want to try to deliver such a controversy issue, right? I have to be careful to represent this, and I do learn much about this one as well. Thank you for the Indonesia Heart Association that gave me the trust to bring this topic. Okay, let me start. The misleading about smokers' paradox. Okay. Yeah. Okay, before I continue this topic, let us understanding about this paradox. What is the smoker's paradox? It's about the unexpected observation that smokers who suffer acute myocardial infarction have lower short-term mortality rates than the non-smokers. Oh, this is interesting. How about the historical context? This was reported firstly in thrombolytic era when smokers show better response to thrombolytic therapy than non-smokers. Sure, there is a misleading term because this term is potentially misleading to the public, suggesting that the protective effect smoking when one exists. Okay, we do know the adverse cardiovascular effects of smoking. There are many researches supported this. It started from endothelial damage, hydrocarbons injure arterial walls, hypercoagulable state, the increasing of fibrinogen and platelet aggregation, the oxygen deprivation, the carbon monoxide reduces myocardial oxygen delivery, the arrhythmia risk that nicotine increases catecholamine release, and the accelerated atherosclerosis when it promotes plaque formation and the progression. Okay. In the thrombolytic era, the crude in-hospital mortality for ME treated with thrombolysis ranged from 2.3 into 4.7. In smokers, 5.2 into 7.6% in former smokers, and 7.0 to 13.8% in non-smoker. This apparent advantage persisted in the percutaneous coronary intervention era. Okay, let us compare the thrombolytic and PCI treatment outcomes. In thrombolytic era, smokers showed greater recanalization rates with thrombolytic therapy, whereas in PCI era, the procedural success rates of PCI were similar across all groups. This was attributed to the greater thrombus burden in smokers. And in PCI era, we do look that 30-day mortality rates, 1.3% smokers versus 1.7% former smoker versus 3.5% non-smokers. So we can conclude that the mortality rate in non-smoker is the highest between these three groups. Smoking-related hypercoagulable state may create more fibrin-rich thrombi that responds better to thrombolytics. The apparent advantage diminished after adjusting for baseline differences. This was reported by Zhang, Lin, Yu et al. In BMC Cardiovascular Disorder 2024. How about the between smoker and non-smoker baseline? In age difference, smokers are approximately 10 years younger at the time of their first myocardial infarct compared to the non-smoker. Fewer comorbidities showed that in smokers, there is lower prevalence of hypertension. Smoker MIs are more thrombotic in nature versus more atherosclerotic in non-smokers, is in different pathophysiology part. And how about the onset? We found that smoking accelerates coronary disease causing events at a younger age with otherwise healthier cardiovascular systems. From multivariate analysis result, smoking status remained independently associated with lower in-hospital mortality. However, the statistical finding doesn't negate smoking's harmful effects on cardiovascular health. From Matrix registry study, 2,456 STEMI patients treated with primary PCI during this period, and smokers were 10 years younger with fewer comorbidities. In mortality, oh, sorry, I lose my okay, sorry for the technical problem. Key findings show that smokers were 10 years younger. And how about the mortality differences? Lower crude in hospital mortality, and the independent predictors show that smoking habit remain protective even after adjustment for age and other factors. Kok nggak kepindah ya? Sorry. From this one. Nah, di situ. Okay. Yeah. How about the ischemic time and mortality? The symptom onset smoker had shorter decision time to seek care. Yeah, it depends on the facility, on the affordable place for the people in the location of the research, right? And the medical context, 60 minutes for smokers versus 77 minutes for non-smoker. Door to balloon similar between group, and total ischemic time showed that non-smoker reached longer than smokers. 2.5% mortality increase per 2-hour delay in general population compared to 3% in non-smoker and 1.8% in smokers. So the mortality increase per 2 hours is lowest in smokers. How about the propensity score matching analysis? From the proposed to balance baseline differences between smokers and non-smokers for more accurate comparison, matched variables consist of age, gender, diabetes, hypertension, dyslipidemia, family history, previous interventions, and cardiogenic shock. And the results after matching smoking remain independently associated with reduced in-hospital mortality with odds ratio 0.44 and 1-year mortality in hazard ratio 0.54. From Kaplan-Meier survival curves, 5.1% first-month mortality in non-smokers, whereas we found 1.2% in smokers, and proportion of all non-smoker deaths occurring in first month is about 43%, where the smoker is lower, 32%. Smoking and coronary structure. Before adjustments, smokers appear to have larger lumen diameter and better coronary flow. Whereas after propensity score matching, smoker actually had smaller lumen diameter than non-smoker. This supported the theory that smoking causes vasodilatation through carbon monoxide production. And carbon monoxide is more resistant to oxidative stress than nitrate oxide. Yes, we know the relation about smoking and coronary function, hypercoagulable state, increased platelet activation and aggregation, elevated fibrinogen levels, endothelial dysfunction, microvascular effects, and plaque characteristic. Okay, from Thai PCI registry study, 22,741 patients undergoing PCI during 2018 until 19 from 39 hospitals across Thailand. The patient distribution about current smoker, ex-smoker, and non-smoker. Non-smoker is majority. The methodology using propensity score matching with inverse probability weighting to balance confounders, and this been followed up in 12 months with 97% completion rate. Okay, we found that the age is older in non-smoker, where a current smoker dominantly with male, diabetes and hypertension is highest in non-smokers. STEMI presentation and cardiogenic shock happen in current smoker higher than the other groups. The PCI registry and MACE rates for current smoker, ex-smoker, and non-smoker, we found that before adjustment, current smoker had the highest rate of major adverse cardiovascular event, followed by non-smoker and ex-smoker. This contradicts actually with the smoker's paradox observed in other studies, right? How about the MACE development? Non-smoker have median amounts to MACE development 13.5, whereas in current smoker is more rapid. It happened in 4.4 and ex-smoker in 4.9. In men, median time to MACE, current smoker is 3.5, ex-smoker 5.6, and non-smoker is the highest. It's about 13.9 months. And the women is the same. The non-smoker is the highest with 6.3, whereas current smoker is the lowest with 2.4. Women develop MACE earlier than men across all smoking categories, and female current smokers develop MACE 3.9 months sooner than non-smoker. This was reported from Limpin Jangkit, Chandavimol from Thai PCI registry on 2022. Malaysia did the same study from 23,108 patients with STEMI, non-STEMI from 18 hospitals across Malaysia. Okay, we're curious for their study. Is it supporting the paradox or not, like Thailand? Okay, from the baseline characteristic, we found smokers were significantly younger, were lower rates in smoker, diabetes, hypertension, and dyslipidemia. We found that STEMI in smoker had the highest rate compared to STEMI in non-smoker, non-STEMI in smoker, and non-STEMI in non-smoker. Among STEMI patients, smoker had more patients presenting without clinical evidence of left ventricular dysfunction. The treatment approaches in Malaysian registry, the thrombolysis primary reperfusion strategy for STEMI in both groups, and low utilization primary PCI in both groups. How about the coronary revascularization? Similar rates in STEMI, It's not different much from smoker versus non-smoker. And the medication, higher rates of aspirin and statin in smokers. We found that in hospital mortality in smoker is lower than in non-smoker. So this supported this paradox. It's different with Thailand registry that we have discussed before. This is called bizarre phenomenon, right? And smoker had significantly lower in hospital and 30-day mortality rates compared to non-smokers. There is 0.51 in hospital mortality and 0.53 in 30-day mortality. Potential mechanism of smokers paradox. Thrombotic nature, we found that smokers' MIs are more thrombotic than atherosclerosis, so it is potentially responding better to thrombolysis. How about the preconditioning effect? Possible ischemic preconditioning from chronic low-grade hypoxia. Enhanced drug response smoking activities, CY, P1A2 enzymes, enhancing clopidogrel metabolism to its active form, and earlier presentations, smokers seek medical attention sooner, resulting in shorter ischemic times. Clopidogrel interaction show that smoking induce CYP1A2 enzyme activity, enhancing conversion of clopidogrel to its active metabolite. This is the plaque characteristic in smokers. Consists of lipid content, vulnerability, and thrombogenicity. Long-term effect of smoking, you know that there is continued damage, persistent inflammation, and endothelial dysfunction, accelerated disease, faster progression of atherosclerosis, and increased mortality, higher long-term death rates despite initial paradox. I should emphasize that quitting smoking after acute coronary syndrome is associated with improved survival. This is the benefit of smoking cessation in subsequent 2 until 10 years by almost 1/2 compared to persistent smoker. The benefits begin to appear within months of cessation. Nicotine addiction, we found that there is a problem, whereas powerful physiological and physiological dependence makes quitting difficult. And from our patients, we usually heard that their weight is increasing when they stop smoking. Smoking cessation may alter the effectiveness of certain medication, and many patients use smoking as stress coping mechanism, especially after a cardiac event. So when they are stressed, they do smoking. How about the strategies? Of course, the first is counseling. I think every nation has this policy. The pharmacotherapy, we do know the nicotine replacement, bupropion, varenicline. Support system is necessary as well. The family involvement, peer support groups, and the digital tools. To address the paradox in clinical practice, please avoid terms like smoker's paradox when we discuss this with our patient to prevent misunderstanding. We should emphasize the long-term risks because the long-term mortality benefit of smoking cessation still exists despite any short-term statistic anomaly. We should consider potential medication interaction and adjust antiplatelet therapy as needed for patients who quit smoking. And sure, there is a need for comprehensive support to provide resources for smoking cessation at every clinical encounter following myocardial infarction. Sure, this paradox supported by the research that has limitation. Let's have a look. Firstly, selection bias. Studies only include patients who survive to hospital admission, missing those who die before medical contact. How about the statistical methods? Different approaches to multivariate adjustment and propensity score matching yield varying result. The definition of smoking may differ between one country with another country. This inconsistent definition of smoking status and lack of quantification back barriers across studies, because the study not explain more about how many time in smoking group. Maybe one people smoke for 1 year, maybe the other for 5 years. This is not explained more detail. And the follow-up duration. Many studies focus only on short-term outcomes, missing the long-term detriment effects on smoking. Sure, there is a need for future research directions about the biological mechanism, the genetic factors, long-term outcomes, and optimal antiplatelet strategies. Never forget about the ethnic and regional variations. Ethnic differences may play a role in smoker paradox. Studies from different regions show varying results. Genetics of cytochrome metabolism, healthcare system. Then we do look at Thai PCR registry found no paradox, while the Malaysia and CVD-ACS registry should strongly support it at its existence. The gender differences in smoking effects, that higher prevalence of smoking among men, and longer time to MACE development compared to women. The conclusion about the smoker's paradox: age factor. Smokers develop MI approximately 10 years earlier than non-smokers with otherwise healthier cardiovascular systems. Smoker MIs are more thrombotic in nature, pathophysiologically, potentially responding better to certain treatments. Any paradoxical benefit appears limited to short-term outcomes and is outweighed by long-term harm. Statistical consideration, the paradox may be partly explained by statistical methods and selection bias. The final recommendation: avoid misleading terminology because the smoker paradox can confuse patients. Emphasize cessation benefits. Quitting reduce mortality by nearly 50%. Individualized treatment, consider smoking status in medical decisions, and promote prevention. Smoking remains a major preventable cause of cardiovascular disease. These are the references that I use in this topic PowerPoints. Thank you.
Okay.
I give the time to moderator.
Okay. Thank you, Dr. Joseph. And he did an excellent job explaining whether smoking paradox exists or not.
Yeah.
And are there any questions or comments to him? Dr. Wan, do you have any questions?
Thank you. I think that it's a very interesting topic because that according to our common sense, we have seldom considered the smoking paradox. However, according to current evidence, indeed the outcomes of the smokers in STEMI or non-STEMI patients seems to be better than non-smokers. However, from my point of view, I think it is because the selection bias. Because that for the non-smokers, the non-smoking itself would delay the onset or the attack of acute myocardial infarction until the later stage in our lifetime, and therefore we can see that for the non-smokers and there will be more comorbidities comparing to the smokers. And to clarify, if smoking is really beneficial for our cardiovascular outcomes, I think that we still have to look into the prevalence of the CV risk during the smoker or between the smoker and non-smokers in general population. However, I'm still very curious about the coronary angiographies between smokers and non-smokers. I'm just wondering if smokers have a higher or lower risk of periprocedural MI, stent thrombosis, or the response to any response during the PCI. Because I think that during your presentations, you have also mentioned that in the thrombolytic era, the smokers seems to have a better clinical outcomes However, it's diminished in the PCR era. So, is there any evidence to or any studies to compare the coronary angiography's results between smoker and non-smoker in AMI patients? Thank you.
Okay. Okay, Mr. Ko Ono, I
Well,
directly
well.
answer. Okay, right. Yeah. Okay. In my limited knowledge, there is no research about the coronary angiography from the smoker and non-smoker. Special study about that. Sure. Maybe for the next research, we may compare the coronary result from the smoker and non-smoker. Maybe it's about the characteristic of the plaque, right? And the technical detailing about that. Thank you, Mr. Yu Chen Wong.
Thank you.
Okay, are there any other questions or comments to this topic? Okay, Dr. Joseph, you said that this kind of the smoking paradox exists in your country, but not in the Thailand. And have similar results been observed in other large groups?
Actually, not in my country. I'm in Indonesia.
Okay.
Yes, the study compared from Malaysia and
Malaysia.
Thailand, right? Yes. Yeah, I think there is a homework for our country as well. Indonesia, you know, we have many population. It's about 270 citizens, and we still we still face the challenge how to reduce the smoker in our country. And sure, this paradox may confuse it all, right? Because the smoker will have an excuse to do the same thing, but actually the bias still the problem in these researches, and we cannot using this in our country, especially when we face our patients, because we should be careful, right? In order to prevent the cardiovascular disease based by the smoking habits.
Okay, thank you very much. And are there any other questions? No? Then time is up. Thank you very much, Dr. Joseph.
Thank you. Warm greet from Indonesia.
And yeah, Dr. Wan, would you please give us the closing remarks?
Thank you, Professor Ono. And for the closing remark, I would like to thank you all for joining today's APSC Cloud Forum. And I think that we have had a truly inspiring session covering a wide range of topics from lipid management and hypertension, polypill therapy to regional challenges and new research and new findings in cardiovascular diseases such as smoker, non-smoker in STEMI or non-STEMI patients. And I would like to express my sincere gratitude to Professor Junli Lin, our APSC new president, and the program director. And I would like to appreciate to Professor Ko Ono, our chairperson, for your great leadership and support. And special thanks as well to all our speakers and for sharing your valuable insight and experience. And finally, I would also like to thank everyone for your participating, patient questions, and the contributions to the discussion. I hope today's forum will spark more ideas and collaborations in the future. And wishing you all good health. And I look forward to seeing you all again at our next APSC event. Thank you very much. Thank you. Goodbye.
Thank you very much.
Thank you.